Okay, so we'll go ahead and get started. Good morning, everyone. I'm Dr. Jackie Taylor. Thank you so much for joining us in our anti-racism speaker series here with the Center for Research on People of Color at the Columbia University School of Nursing. We have the distinct pleasure of having with us today Dr. Timiya Nolan from the University of Alabama, Birmingham. She is an associate professor in the Division of Preventive Medicine and associate director of community outreach and engagement at the O'Neill Comprehensive Cancer Center at the UAB. Dr. Nolan studies issues in self-management and prevention of chronic conditions, including breast cancer and cardiovascular disease. Her community-based research program is looking at ways to improve the quality of life and health among individuals from underrepresented and underserved communities. She is the co-organizer of the Ohio State University's Health Equity Through Diversity, From Communities to Clinics to Clinical Trials webinar series. Dr. Nolan's work has been supported by the National Cancer Institute, the American Cancer Society, the Susan G. Komen Foundation, and many others. She earned a BSN, a MSN, and a PhD at the University of Alabama at Birmingham School of Nursing and completed postdoctoral training at the Ohio State University College of Nursing. She was recently elected a fellow of the American Academy of Nursing, so congratulations. And personally, she is a proud wife, mother of two, and happy to say my sorority sister in Alpha Kappa Alpha Sorority Incorporated. So please join me in welcoming Dr. Timiya Nolan as she speaks to us today about charting a course for inclusive excellence from clinics to communities. Thank you so much, Dr. Nolan.
Thank you. I appreciate the opportunity to be in this space. For you, those of you who do not know, I count Dr. Taylor as one of my mentors, and I've known her for a very long time, since 2017 when she was at Yale. And so it's great to be able to really have the opportunity to have this full circle moment. And so I do want to, take the opportunity to tell you a little bit about how I approach research and really how that research spans from the clinics and our academic health systems out into communities. And so while I have this time here with you all today, I will endeavor to meet these objectives, to describe the current health inequities that I'm seeing in the work that I'm doing, to talk a little bit about traditional and contemporary research methods, examine inclusivity within research, and then identifying solutions to create inclusive excellence. And so where's the problem? So, as we think about where we are today, we know that over time we have increasing in diversity. So basically by 2045, Black and Brown Americans will definitely outnumber white Americans. And so this presents a problem that, we definitely are not as diverse in our academic health systems, and we're not as diverse in those individuals who are treating and caring for this increasingly diverse population of Americans. With that, we are also seeing problems with health disparities. And so as we think about the top causes of death, which are heart disease, cancer, unintentional injury, and COVID-19 still hanging up there, these disproportionately affect Black Americans. And so there was a recent publication in JAMA where the authors actually did some research and actually found out that over the period of the last 22 years, Black Americans had 1.63 million excess deaths in comparison to white Americans. That is staggering. Staggering. We know that these disparities are definitely linked to things like racism. So I'm so happy that you all are tackling racism in this series, because we know that it is systematically affecting every aspect of being in our society. Whether you think about wealth gaps, whether you think about poverty, whether you think about redlining, racism is at the root of all of this. And then last but not least, We have this increasing diversity. We have health disparities. We have racism, and to top that all off, we also have poor clinical trial diversity. And so, in general, as we look at the FDA, they said that 7% of participants are identifying as Black Americans, but when we look at the U.S. population, Black Americans make up about 13%. So certainly, the information that we're learning, these groundbreaking studies, are probably not going to be as representative and probably not going to have the same impact that they could had they been diversified at the beginning. And so these are problems that we're seeing, but I want to drill down a little bit further and help you to see what that looks like where I am in Alabama. And so the problem in cancer, mortality here, as you can see, is definitely high, and it's high in comparison to the United States. But I want to draw your attention to this map. This map here, where my cursor is, actually shows the Black Belt area. And so for Black Belt, what that means, it's not just the soil that's Black and rich and grows great produce, but it also represents an area that has a very high concentration of Black Americans. And so in this slide that you can see here, we also see that Black Belt area has higher mortality as it relates to cancer. It's darker as it relates to cancer in comparison to the rest of our state. And so certainly, that presents a challenge. Now, even when we break that down by the top 7 cancers that are important to our cancer center, which are brain, breast, cervical, colorectal, lung, pancreas, and prostate, we see that we definitely have disparities there. The only places where we have whites who are dying at higher rates than Blacks are actually with brain and lung cancer. And so we're not really sure why that is with brain, but with lung cancer in our state, we have more white Americans who identify as smokers in comparison to Blacks. And so that's why we think we see the issues and disparities there. But with the other cancers, breast, cervical, colorectal, pancreatic cancer, and prostate, we see higher mortality in Black Americans. And particularly, it's interesting here also that when we look at breast and cervical cancer screening in the state of Alabama, Black women actually do better than white women. And yet still, we are seeing the higher mortality rates among breast and cervical cancer in Black Americans. And so there's certainly problems that are there. And we know, again, that those age-old issues that stem back to racism are likely one of the very large factors that cause what we're seeing here. And so just to give you another look at this and a more expansive view looking at the United States. So with breast cancer burden, we're expected to have over 280,000 new cases from 2022 and over 40,000 women dying. But, as incidence rates have increased across all demographics of U.S. women, there are especially higher rates or higher increases in those rates among Asian Pacific Islanders and in our indigenous populations like American Indians, American natives and Alaska natives. And so, definitely we're seeing that as an issue. But, by and large, when we look at mortality rates, we're definitely seeing that non-Hispanic Black women are dying. And over here in this graphic, you can see it's about 40% higher than non-Hispanic whites. And so this gap continues to, persist over time. And, we definitely need to figure out ways in which we're able to start to dismantle the systems that are perpetuating such disparity. And so even though we look at just breast cancer in that respect, it's also incumbent upon us to know that these things do not happen in isolation. Most individuals who are affected by a chronic disease actually have another comorbid chronic disease. And so this central illustration here shows the impact of social vulnerability on cancer and cardiovascular disease mortality. And so as we can look at that centerpiece, we see that those individuals who have comorbid cancer and cardiovascular disease actually have higher mortality rates. And so these individuals who happen to fall into that category, more likely to be older individuals, more likely to be female, more likely to actually identify as a person of color. And those highest age-adjusted mortality rates actually happen to be Black folk. And so, definitely, again, racism is prevalent. Racism affects our economic status. It can affect our household composition. It can affect the languages that you speak and understand. It can affect where you live and how you are able to move and be in your space. And so there's only, as we think about ways in which we're trying to make a change, we have to think about solutions that are multi-layered, solutions that are multi-level. And so with, thinking about moving forward, it's resource allocation. You've got to put your money where your mouth is. You have to put time into education, but then also thinking about how do we begin to integrate the concepts around the social determinants of health into our clinical care delivery systems, and really thinking about sustainability and how we make those things stick. It's about targeted policy interventions. And so multi-layered, in which we are thinking about being able to ever close those gaps that we're seeing in relation to mortality and comorbid disease. And so also giving you just a little bit of information about this. So 6% of those living with breast cancer have pre-existing cardiovascular disease. And then after the disease, after a breast cancer diagnosis, about 11% are going to develop the breast cancer. And so, again, these things do not happen in isolation. And so as I am taking on this new role at the University of Alabama at Birmingham, it's certainly a pleasure for me because I'm back in the place where I literally grew up. I did all my training at the University of Alabama at Birmingham. Coming back and being from Bruton, Alabama, which is a very small town in South Alabama, seeing individuals day in and day out dealing with hypertension, dealing with cancer, dealing with all kinds of chronic disease, and that seeming like a norm. It's for me coming back, in this new role, but having the same passion that I really want to affect those systems and affect this reality that many Alabamians are living in. And so in this role, our goal is of our Office of Community Outreach and Engagement is to reduce cancer burden and disparities in Alabamian communities. And we do that through 3 E's. We do that with evidence. We want individuals to be a part of the creation of that evidence as well as the dissemination of that evidence. We are looking forward to, having education and making sure that individuals have the information that they need to be able to act on their ability to reduce their risk of developing a cancer and to manage a cancer. And then lastly, empowerment. It's not enough to know, but you have to begin to do. So how can we empower and provide supports for individuals to be able to do what they need to do to reduce their risk? And so we have 3 basic aims that are not unlike other National Cancer Institute recognized NCI recognized or designated centers. And so we want to be able to help to understand that catchment. We want to, which is our whole state of Alabama, all 67 counties. We want to promote and support collaborative and cross-disciplinary research to address cancer disparities, which really entails being able to really have crosstalk and being able to have bidirectional conversations and collaborations with our community and our health systems and others. And then lastly, to implement evidence-based practices that are going to reduce the cancer burdens that we're seeing in our catchment area. And so those are, very big aims and very big goals and things that certainly are going to take a lot of time to try and even attain. But, I posit to you, if not, now that we start to try and address, then when. And so being in this space, I actually had the opportunity to attend the American Association of Cancer Institutes meeting with the new president, Dr. Rob Wynn. He is actually the Cancer Center Director at VCU Massey Comprehensive Cancer Center. And so this was his presidential initiative. And he talked about how it was important to think really big and broad about excellence, and not just excellence, but inclusive excellence. And so, he had these 5 pillars, thinking about how we have diversity in clinical trial and making clinical trials more accessible, having funding, thinking more so about the diversification of those accruals. He talked about how we need to diversify our faculty, and then with that diversification, making sure that we retain those faculty. He talked about the patient access and health equity issues that we're seeing, and ways in which our health system can align to better service and the folks that we have out in our catchment areas. Making sure that we have navigation and that we're addressing any barriers that they might be to them, begging it to our cancer centers. And then last but not least, he talked about diversity, equity, and inclusion. And as I think about that, we've been beating that horse. But as we think about those 3 letters and what those letters mean, it comes down to having access. It comes down to belonging, and it comes down to really thinking about how culture shapes these health systems and ways in which we can bring people in. And I really, that resonated with me, and it's why, you see that I wanted to make that a focal point of this presentation today. And so what about these inclusive frameworks? So definitely there's levels of community engagement in research. And so like anything else, there's a range from good, better, and best. And so certainly it's good that we have community members as the focus of our research. And for those of you who are like me and who are really into making sure that you have service that aligns with that research, okay, it's great, to have community members there. But it's even better when we start to engage those community members as, stakeholders. And so having responses or having research that is responsive to things that they have told you, and responsive to the area assessments that we have completed. But it's best when we actually have community members who are part of our research team. And I'm not just talking about, again, the surface level, we got them on our grant, but how are those community members really influencing the work that you're doing? Do you have a community advisory board who's truly working with you and not for you? Those are really, salient questions to ask yourself. And, as we're thinking about ways in which we're moving forward, certainly our funders are really supportive of community engaged and community-based research. PCORI, Robert Wood Johnson Foundation, even NIH and their community partnerships to advance science for society. They want us to be able to incorporate the community voice into the research. That's only going to improve the ways in which we're able to do the science, and improve the ways in which we're going to be able to upscale and sustain the work that and the interventions that we're creating. And so it's imperative that, as we are going through our journeys as scientists, and going through this journey as clinicians, that we begin to open our eyes to the value that community voices can add. And so just as a thought around a framework to use, one of the things that I've used in my research is called the PETAL framework. And so with PETAL, really what you're trying to do is you go through a process of learning and trying to improve. And how you try and do that is that you are really acting on the data. You are focusing on the health disparity. you are at all levels prioritizing health equity, and most importantly, you're engaging communities. And so what does that look like? I know this picture's a little fuzzy, but it looks like rooms like this, where we have literally academicians, clinicians, government officials, we have industry partners who support this work, and we're all at a table and we're talking about one thing, and we're trying to align on how we move forward, how we act on the data, and how we're going to include our community members that also are sitting around that table. And so that's what it looks like. And others who have kind of talked a little bit about these multi-level frameworks and inclusion is also folks who ascribe to the Cells to Society framework. And so Cells to Society is literally now it's becoming very, very common. You may have seen models from the American Cancer Society. The National Institute of Minority Health and Health Disparities actually has a really nice framework. You might have seen the late Dr. Warnicki's model that literally, moves from the smallest parts of people all the way up to the society level, and the policies that kind of are enveloping this whole system, and how they highlight the multifactorial influences on health outcomes. And it's important to note that really with Cells to Society, we're understanding that human beings do not exist in a vacuum. We are complex, we're adaptive individuals, we are social, and because of that, there may be changes along the way. In a recent article by Dr. Reader Hayes and colleagues, they also talked about how we can use the Cells to Society model really in our research and what we need to do. And they had 5 major points that they brought up. They talked about defining racism. Again, it's so important to understand how racism is a factor in this whole ecosystem of health disparities that we're seeing. They talked about exploring the interwoven factors, and so how we're constructing our how we're constructing our models need to really have a component in which we are not identifying and not really excluding out all of the confounding factors that may exist, but rather really how they coexist. It talks a lot about increasing representation, and not just representation in the individuals who are participating, but then also representation with the whole team. And so we know that lived experiences color the way in which scientists think about a question and will interpret the answers. Importantly, they talked about centering Black Americans, centering the community, those individuals whom are proximal to the issue. And then last but not least, at every step of the way, evaluating whether or not equity has been at the center of what you're doing. And so that harkens back to the PETAL framework. And so literally thinking about ways in which we can enlarge the way that we're thinking about problems and also their solutions. And so here's an opportunity to be a little bit interactive. Are you including community voices in your research and or your service currently? Pop that in the chat. Maybe I put everybody to sleep. Well, I'll just go with it. Okay, we have no.
I'll say something.
Okay.
And I want to say, like in our recent U54 on maternal health, I think I saw that they're on the call too. Victoria St. Clair, one of our community partners, also is one of the PIs of the entire U54. So we're definitely including community voices in the research and service that we're providing.
Awesome. And I see a couple in the chat who are already including community voices as well. That's amazing. And if you're not doing that as of right now, you know what? this is a perfect time to start thinking about how you might be able to do that. And so I hope through listening to this presentation that you will get some ideas and even get the courage to make some friends across the aisle, whether that is in community, whether that is in government, or even in industry. And so what we learned from the COVID-19 response is that anything is possible if we listen and work together. It harkens back the thought, or the African proverb, if you want to go fast, go alone, but if you want to go far, go together. And that's absolutely what we did as a nation. We put our resources, whatever those resources were, whether that be funding, whether that be relationships, we put all of those things together, and we were able to move in record time. We were able to save lives. And, you know, as we learn from that response, it's about us really being proactive to create those mutually beneficial partnerships and have aligned mission and values, because we have to absolutely learn and continue that learning so that we can apply that those wonderful gains to other problems that are coming and that we're faced with. And so it's really about having a growth strategy. And so what we did while I was in Columbus, Ohio, is that in the height of the pandemic, we realized that individuals who were marginalized systematically were literally not able to get masks, not able to get supplies that would protect them from COVID. And so what we did was we organized a host of academicians, clinicians, government officials were out there. You know, our mayor supported us. We had the African American Male Wellness Agency, who has a tremendous reach across our city to help us to spread the message. We had L Brands, the Bath and Body Works, who gave us hand sanitizers, and it was just absolutely amazing how we came together. We used what we had to be able to have a greater collective whole, and we gave away thousands, hundreds of thousands of supplies to folks in the most vulnerable 5 zip codes across the city of Columbus. And so that was amazing. And it's important to note that all of those partners whom we had actually supported us in a research project that we had actually kind of just before COVID. We were putting together these teams. We had, American Cancer Society. We had our competitor, Ohio Health, that was on board. We had City of Columbus on board, American Heart. The list goes on and on and on. This is just a small smattering, but we had put these folks together because we had identified an issue in cardiovascular health. African American men had poorer cardiovascular health than any other group of Americans. So whether thinking about male or female, as well as the racial and ethnic groups. And so we as a team wanted to be able to think about ways in which we could reduce the disparities that we were seeing, that we could address cardiovascular health in Black men. And so with our partner, the African American Male Wellness Agency, what we did with them is that we said, okay, you have these annual walks. Literally, we were screening about 1,000 Black men every year. And so we were doing all of the Life Simple 7, which is American Heart Association's their previous American Heart Association's previous definition of cardiovascular health. So blood pressure, blood cholesterol, blood sugar, smoking status, weight, physical activity, and diet. And so we identified individuals from that walk who had less than 4 ideal metrics, and we paired them with health coaches and community health workers and personal trainer. And so these men in teams actually came together once a week for 24 weeks for 45 minutes of health education and 45 minutes of that physical activity with that trainer. And so we were really interested to see how we were able to, have that community health worker look at engagement with primary care, looking at their social needs. We wanted to definitely see the primary outcome of how we were able to affect cardiovascular health, and then also looking at social support and patient activation. And so that was the primer for, putting all these partners together. And we were able to literally have a robust response to COVID, because we said, all right, well, we've got all these people in the room. How can we make that salient to the situation at hand? And so, this was great, because after the pandemic, we, started up. It was July of 2020, and we finished in December. And so what we saw was that our Black impact intervention actually improved cardiovascular health by about 1 point. And so that lowered the risk of mortality by about 19%. It was absolutely amazing to see the change that happened with these Black men, a population of individuals whom are typically deemed hard to reach, but we were able to actually have less than 10% attrition across that study, because we involved the African American Male Wellness Agency, who has tremendous community outreach and engagement experience, to help us to learn how to ensure that we could keep people in this intervention. And these are just some of the quantitative results, but certainly qualitatively, we saw that we definitely had improved lots of other aspects, and that individuals really saw social support being high, not only between their peers, but also from us as the health as the clinician scientists who were leading as well, who actually happen to all be racially concordant. And so, this is just, again, a testament to how we can all come together as a mutually beneficial team, and then try to figure out ways that we can reduce disparity. And so that, again, those partnerships, we kept them rolling. Academic, community, government, industry partnerships. And so while I was at The Ohio State, I started the Partnering and Negating Statistics for Black Women, or PINS for Black Women initiative. And so with that, we really sought to help Black women, uplift Black women to achieve total wellness through provision of education, access to resources, and partnership in science. And so we did this to really try and inform inform future co-built interventions like the Black Impact study, that Black Impact intervention that we had. And so, through this work, we were able to have an Uplift Her Women's Health and Wellness Day. We've had 3 of them. And so in that center picture, we actually had Congresswoman Joyce Beatty, who was our chairperson in this past year. And it was absolutely phenomenal. Over the course of the 3 years, we've seen over 1,000 Black women. We have screened over 500 of those Black women. We have been able to identify that those individuals have less than ideal cardiovascular health, much like the numbers that we're seeing with BRFIS data that's nationally represented. And so we have right now a R34 resubmission that's under review, so that we can think about or we can try and adapt that Black impact intervention for Black women, and see what kinds of effects that we're able to achieve there. And so all of this, this work is partners who are out and presenting their information, their education, community health workers who are there, who are doing social needs assessments, patient navigators who are getting people identified for screenings on outside of the days. And then actually this past year, we did 40 mammograms on site, and about the same amount of pap smears. We did ABI for the first time this time as well. And so this event continues to grow, and it's not just in Columbus, because the African American Male Wellness Agency has now begun to do this in other cities. And so they have 5 other cities that they're now doing these types of events at. And so it's absolutely wonderful that I have been able to be a part of this, but then it also has a component where we are really plugging people back into research. We're going out into their neighborhoods. We're showing them that we're not the big bad wolf, and we're not the individuals who are just going to be dissecting you, but we are actually people who are working with you. And so thinking about this whole context of moving forward, it's about us thinking about global equity. And so how can we move from our clinics to our communities and really use the value that clinical trials can have? And so it's about us thinking about in nursing, how can we retool nurses to provide equitable care? Looking at yourselves first, and then thinking about how can I leave my preconceived notions, my biases at the door, and really look at this patient as an individual, and that individual has needs, and that individual has a set of circumstances that has caused them to come into the clinic where I am. It's about thinking about our communities. We know that traditionally our academic health systems have not been the friendliest to individuals of color. That is a fact. Again, this is the anti-racism series. We know this, but it's about leveraging community engagement to regain trust, but trust must be earned. And so it's incumbent upon us to look at ourselves, look at our systems and ways in which we can begin to change and dismantle those systems of racism that have caused these disparities that we're seeing. And then lastly, with clinical trials, it's about us having a concerted effort about how we're going to diversify our clinical trials. Every single cancer center has to report on the number of clinical trial accruals that they have and report on how that looks like their catchment area. I'm happy to say that at UAB, we are doing actually better than the percentages of Black Americans. And so, it's just amazing that there is the level of expertise that's allowing us to really meet our diversity goals. But every single cancer center cannot say that. And it's an opportunity and an imperative for us to learn how to do community engagement, not just outreach, but engagement to improve the accruals that we have to our clinical trials. And so this brings me to our Health Equity Through Diversity series. And so as we thought about what we needed to do, myself, Dr. Joshua Joseph, who is at The Ohio State University, Dr. Daryl Gray, who is now in the private sector, came together and we said, you know what? We need to be able to have conversations that span not just with our academic health systems, but also bring in community members, also bring in community organizations, also bring in government officials and industry partners to think about how do we change what we're seeing. And so we had a webinar series that we started in 2021. We talked about 4 things. We started with talking about clinical trial diversity. We then followed up with community partnerships. The third one was that we talked about the need for our workforce diversity and improving our pipelines. And then lastly, we talked about the huge issues that we have of inequities in technology. And so it wasn't that we just invited panelists to come and give information to people, but we had these multi-sector panelists come, set the stage, and then we had breakout sessions where we were intentional about having multi-sector participants answer a specific question, and then we left out with a call to action. And so it's all about action. And when we did those 4 webinars, it was apparent to us that it wasn't good enough. We needed to start thinking about how do we get people in a room to have these robust conversations, because Zoom, this is great, but, having the ability to talk to people in person, to really see somebody, to think about developing a relationship. So that's something that really happens when you're together in a space. And so with us, we had our inaugural conference that happened on last year, where we followed that same kind of structure. We had the multi-sector panelists have conversations. We had, a part of after each of those sessions was, question and answer type of a thing. And we left out with a call to action, and it was great. It was amazing. We had about 100 folks who came to that first one. Majority of those individuals were community members, and that was by design as we sent out our invitations. But it was like, you know what, we got to continue to do this. And what can we do to not only have conversations like that, but move forward? And so with the second conference that we had this past October, we had an opportunity to partner with the Ohio State University's Public Health, but also the City of Columbus, to make it a broader conference where we looked at not just the health equity through diversity, but also an action learning series that the City of Columbus put on about anti-racism. And so we had those multi-sector panelists. Again, we had robust breakout sessions, but we had also sessions where we were collaborating and cultivating the next steps. What can we do? How can we bring academic community, government, industry folks together to be able to move the needle? And so those working group sessions, I'm happy to say that we are writing a publication right now on those findings. But if you are interested in knowing a little bit more about Health Equity Through Diversity Conference, I invite you to just use the QR code there, and the web page is hetdconference.com. And so this is some of the work that's come out of this Health Equity Through Diversity series. We have been able to publish this paper, Community Engagement and Clinical Trial Diversity, and which really highlights 4 big areas that, they could be barriers, but there are solutions. And so certainly barriers to access, barriers to awareness, barriers to race, such as racism, and barriers within the workforce diversity. But I posit to you, it's incumbent upon us to think about the solutions and how we're going to address all of those barriers. Also, here is a graphic depiction of what happened at this year's meeting. And so health equity action and learning was, our theme, and how can we have conversations and really, cultivate the opportunities to work together and really collaborate to make opportunities as best as they can be. And you can see, so literally, using your relationships strategically, inviting those partners, leading with race-based health initiatives, that if we do that, it's going to lift everybody up. Thinking about ways in which we're interacting with our patients. We need to lead with humility. As we think about this, what is health equity? It's literally thinking about diversity. It's literally thinking about access, belonging, culture. And it's all of our responsibility to be thinking this way and really changing and acting to be able to move the needle. Because, as we're looking at the ways in which these systems have, interplay with individuals, we know that we've got to be able to help, and it's about changing our mindset. And so as we're thinking about those individuals who are going to help us to do that, we absolutely, again, have to diversify. We have to be able to have supportive environments, not performative, and, really transforming the talent that we currently have to support the issues that we are seeing to be a solution. And so we are, so excited about how, this work is really, it's enriching personally, but also the ability to disseminate this information and hoping that it will begin to trickle down into other spaces and people's hearing and being. And so the question that we come back to is, How do we effectively build and foster multi-sector partnerships? In my Office of Community Outreach and Engagement, we have a pretty large structure. So we have about 7 in-house staff, including directors and individuals who are supporting our research relations, our outreach and education, our patient navigation program, and also evaluation. We have county coordinators who you can think about like community health workers. And we actually have 2 of our 24 who are now certified as community health workers. And we're working to change, and that's just happened in the last a month or 2, and we're working to get everybody certified as community health workers. And underneath those individuals, we actually have community health advisors. These are natural helpers, and they're unpaid. And we have about 402 of those individuals across the state of Alabama. We have a robust community advisory board. We have research program liaisons. We have community organizations, government organizations, industry partners who are all working together to try and reduce cancer burden and disparities that we're seeing in our Alabamian communities. And how our office really operates is that we have goal-directed, bi-directional communication. We are action planning, and we're doing that with the spirit of inclusive excellence. I cannot say that anymore, but it's all of us together. We're rowing the boat in the same direction. And some keys to partnership that I've learned along the way are definitely to diversify. One messenger, one thought, one individual cannot help us to go where we need to go. Certainly, as we're in this office, we are seeking to diversify those natural helpers. The majority of individuals, we have a very good problem. Majority of those individuals are middle-aged Black women. And so, as I mentioned earlier, we have literally turned the tide in breast and cervical cancer screening in our state. So Black women are more likely to be screened than whites. And it's because of these community health advisors, these natural helpers. And so we have to diversify those natural helpers so that we can then begin to bring in some individuals who have different racial and ethnic backgrounds, but then also other intersectional identities, individuals who identify as LGBTQ+, individuals who may have disabilities. We're, working with our Alabama School of Deaf and Blind to be able to bring an individual on for that point. And we're also working with our historically Black Greek letter organizations to bring in younger folks to the fold as well. And so all about diversifying. And as we do that, we're listening not only to respond, but listening with the intent to really internalize and use that information that's coming into our hearing to the greater whole. We're developing a shared goal. We're recognizing and utilizing strengths. We're co-creating and we're evaluating and constantly reiterating so that we have the best outcomes. And so I'll leave you with just a few comments. So certainly we hope that you all may visit us next year at UAB as we're bringing the Health Equity Through Diversity Conference to Birmingham, Alabama. But, it is incumbent upon us to practice inclusive excellence, whether you're a clinician, whether you're a scientist or a member of the community. We all have to work together. Collaboration and partnership across the sectors, it can be, variable. It's really dependent on who has what kinds of resources. And it's not always dollars, but it could also be capital of knowing people and relationships. But we have to do this because we've got to be able to respond to, got to be able to be proactive toward the multi-layered challenges that we're seeing as it relates to social determinants of health, like racism. And then last but not least, certainly I don't know that there is an answer, one size fits all, but academicians, community members, government officials, and industry affiliates are in need of tools to harmonize respective approaches toward the support of better health outcomes. And so I want to thank the wonderful team members who have been a part of this work, both at The Ohio State University and at the University of Alabama at Birmingham. It takes a village. And certainly I love some dialogue with you all, and hope that this information has been, sweet in your ears.
Thank you so much, Dr. Nolan. It's so wonderful to hear about all the great work that you're doing. And I'd love to open this up to question and answer for the audience here. But I just wanted to also say that I had the opportunity to come to the Ohio State University for the conference that you put on, and it was absolutely fantastic. It was I think it was the only conference that I had been to where I saw so much community involvement and so much crosstalk with community members, researchers, clinicians, and it was just fantastic to be a part of it. So for those of you doing community engaged research, I highly recommend this conference if you can make the time to attend.
Thank you.
Dr. Bakken, I see you have your hand raised.
Yes, thank you so much, Dr. Nolan. And this isn't so much a question, but just a reaction to your last comment about the needed tools. The NIH is just undertaking a 2-year working group called Engage. I know there's other projects called Engage, but it is and I am the co-lead of that working group along with a patient advocate. And so I can put a little more info in the chat, but one of the things that is just really moving us from the need to engage, but also making sure that researchers have the right types of tools and tools that are tailored for the population. Because what ends up happening is people like you have developed things, and then somebody else goes and they kind of develop it, from scratch. And I'm feeling optimistic that there is some recognition that we really need to move from having some strategies to help with this to creating more of a toolbox that will facilitate these types of equitable partnerships and engagement strategies over time. And so I just thank you so much for your amazing work.
Thank you. And just, as a response to that, what I'll say is that you hit the nail on the head. There are people who are already doing these things, but it's about identifying what resources you have within your institutions and who those individuals are, and starting to create, partnerships, relationships with those folks, and then leveraging that to then do the work. But, I think that one of the things that we all kind of struggle with is in large institutions, especially, how do you know what everyone's doing? So even just yesterday at UAB, we had a meeting that our Collaborative Health Equity Council put together to bring folks who are doing community outreach and engagement across our institution together for the first time. And so, we've got to be able to know what kinds of strengths there are, and certainly love to hear more about the working group that you mentioned.
Let's see, Derek McCracken, you have your hand up.
Morning, everyone. Thank you, Dr. Nolan, for this great information. I am on the teaching faculty at Columbia's Narrative Medicine program, and we are always looking for ways to improve our relationship with the community. And the reason I typed in something about health literacy, you had mentioned bi-directional communication. And so I'm curious, what role can health literacy play or can play in mitigating the negative impact of unequal access and unequal delivery of care? And I will say that most of the work we do is on a smaller scale. So not so much an entire organization as it is like an agency working with a specific population.
That's a great question. So actually, in our office, we have been working with Dr. Gabrielle Rock. She is a medical oncologist, but she has a really keen interest in digital health literacy. And so she's partnered with our office to be able to work with our community health advisors and our county coordinators to go out and really give people tools so that they know how to access things like their own patient medical, their medical record, and how to get those, simple summaries after care. And so those are some of the key pieces that are helping us with our health services. But then also, as we think about research, one of the things that we have done and are rolling out right now is we have our CRAFT Academy. CRAFT stands for Community Research Academy to Foster Representation, and it's focused on giving community members on a train-the-trainer basis a way in which they're able to know what a clinical trial is, what it is not, to hear from other individuals who have been participants in clinical trials and understand their experiences and how that has enriched their lives. And then lastly, to give them tools so that they know how they can then become a participant. It's not just asking your healthcare provider, but then also things like Research Match. And I'm sure that Columbia also has kind of a website or something to that effect that actually lists open trials that individuals can search. And so it's about giving people the knowledge and then supporting them to be able to act on the knowledge that is given. And then for us, it's also about leveraging those relationships. So if something goes awry, they can always reach back out to our community, community health advisor, or reach out to our county coordinator for more information. And so certainly we know health literacy is a huge barrier, but it's not insurmountable at all. It all goes back to leveraging those, really leveraging relationships, leveraging information, and providing resources to support individuals to do those things that we need them to do.
Thank you so much. Are there any other questions before we? Oh, I see something in the chat. Oh, we have, thank you to all of you for, we have a question. Dr. Alexandria Jones-Patton, she is a postdoc with our Center for Research on People of Color.
Nolan, thank you so much for your presentation. As Dr. Taylor said, I'm one of the postdocs here at Columbia, actually being mentored by Dr. Taylor, and I look a lot at racism and discrimination and how that influences heart health. I'm a millennial, so I'm always thinking about, where other millennials are, not only in research, but in healthcare and being providers. So you spoke a lot about community engagement, and I'm wondering if some of your people, your stakeholders within the community, if they are in the millennial group, and how we can get them to transition into being providers or into taking more of that leadership role so that we can have more open dialogue, but also push the needle for real actionable change with dealing with some of these issues around cardiovascular disease and cancer disparities among racial minorities.
Absolutely. So with our community advisory board, our community advisory board is very diverse. So whether you're thinking about age, whether you're thinking about race, whether you're thinking about, where these individuals are living, rural, urban, social economic status, we have 20 individuals who volunteer their time to really direct us at our cancer center. And certainly, they bring up issues about the stark realities, as I mentioned earlier, is that we have county coordinators and community health advisors who are primarily middle-aged Black women. And so we've got to change that. And so right now, I've only been in this space for about 5 months, but it is one of my initiatives to increase diversity, particularly among age, LGBTQ+, as well as disability status. And so, if you're not at the table, then we're not hearing your voice. If you're not at the table, I know people have also said that you're on the menu. And so we know that we've got to definitely diversify. And certainly as we think about our workforce, we have a robust CERTEC program that starts from high school and goes all the way through traineeship at UAB. It also includes historically Black colleges and universities. We work with Morehouse School of Medicine in Tuskegee very closely. And we've also been instrumental in starting a program at the Alabama State University, which is another HBCU. And so, it is about really having concerted efforts and really understanding that we have to move the needle as far as workforce diversity comes. We're doing much better, I believe, in our undergraduate programs. But we've got to, kind of span that along. So I don't think that any, I'm just speaking about cancer centers, I don't think that any cancer center looks like their catchment area with regard to their clinicians and their healthcare staff. But again, it's not insurmountable. It's about us really putting that at the forefront and having dashboards where we're tracking that. Who are the faculty? Who are the recruits that are coming, and how are they faring out? And looking at retention rates. These are things that should be top of mind and at every single faculty meeting, because if you're talking about it, then inevitably you'll start doing something about it.
Thank you.
Thank you so much, Dr. Nolan. We have learned so much from you today. The work that you're doing with community engagement and research in cardiovascular disease and breast cancer is just absolutely outstanding. So we just, I'm so proud of you and all of the work that you're doing. And I'm just, it's been a pleasure to watch you grow and just soar in this work to reduce health disparities among vulnerable populations. So thank you again for being here and sharing this great work with us. For those of you still on, please feel free to go in the chat and fill out the survey. Those of you at CUIMC and NYSPI, you can also complete for continuing education credit if you would like to do so. So thank you again, all of you, for attending. It has been a pleasure, and we look forward to hearing more from you at the Health Disparities Conference at UAB. Talk to you soon.